So I welcome everyone. This is actually our visiting professorship program. Some people are seeing this live on a webcast. Hopefully many others are going to be able to see it on the archive. Just a few announcements. People can access this if they're seeing it live. Obviously, they've accessed it in CC Live Cases. You have to register. Registration is free. And then you have the ability to look at other content there. It's actually the home base of Dr. Sharma's Live Cases. Just as a reminder, if you want to attend really an excellent course, Dr. Sharma's course is June 11th to 14th. It's called Complex Coronary Valvular and Vascular Cases. To register, go to cccsymposium.org. This program that we run on a monthly basis we'll have again in May and June, and then be off for the summer. What we usually invite is an internationally renowned professor who spends the day with the fellows. Today we were very lucky to have Rick Nishimura, and the people really, the fellows said it was one of the best experiences that they've had, and they see why he's renowned as a world-class teacher in cardiology. I just want to tell you a little bit about the format. As we usually do it, the fellow will give a short presentation on the subject matter, and then we're privileged to have Dr. Valentin Fuster, who's director of Mount Sinai Heart, physician-in-chief, moderate a panel discussion. Since I never really do it on a regular basis, I'll just tell you a little bit about Dr. Fuster. He is the physician-in-chief. He's also the general director of the equivalent of the NIH in Spain. He's one of two people in the world who was given the formal title as Legend in Cardiology. The other one was Eugene Braunwald. He's past president of the American Heart Association, past president of the World Heart Association, and the only person to receive all gold prizes from all four major cardiology organizations around the world. He moderates the panel discussion. Our distinguished panel includes Dr. Nishimura, who you'll hear about formally from Dr. Fuster, Laurie Croft, who's our non-invasive expert, Dr. Desnick, who's Dean for Genetic and Genomic Medicine, Professor and Chairman Emeritus of Genetics, Dr. Anu Kinney, who's a Professor of Medicine, Director of the Cardiac Cath Lab, Mark Miller's Assistant Professor, who's going to represent electrophysiology decisions, and we've invited Paul Stelzer, who I know may be in surgery, and if he's not available, we're going to have a substitute from surgery. I wanted to thank Dr. Sharma, who sponsors this program in dedication to his father, Ricardo Samariba, who takes care of the webcast, Guy Puglisi, who's in the back, who handles the broadcast, Beth Oliver, Mayra Viruit, and Rob Southwick. Without further ado, Antoine has prepared an excellent monograph.
Good evening, everybody. Dear Dr. Fuster, dear Dr. Goldman, thank you for giving me the opportunity to present an interesting topic in the cardiovascular field titled Hypertrophic Cardiomyopathy with our visiting professor, Dr. Rick Nishimura. Since its description in the 1950s, hypertrophic cardiomyopathy has attracted intense interest related to growing awareness of its prevalence, estimated about 0.2%, its role as the most common identified cause of sudden cardiac death in young people, and its segregation as a mandated autosomal dominant trait. It is characterized as a focal and asymmetric LV hypertrophy in the absence of other disease state that could explain such hypertrophy. Positional cloning and candidate gene studies have identified more than 140 mutations in 11 sarcomeric protein genes, leading to the widely accepted suggestion that HOCM is a disease of perturbed sarcomeric function. Initially, these findings led to the enthusiasm in labeling these mutations as being of high, intermediate, or low risk of sudden cardiac death. Although some of these associations are relatively robust and provide clinically relevant genotype-phenotype distinctions, or correlations, there is significant variability within and between different pedigrees within the same mutation, which might reflect other genetic and environmental influences. Thus, the clinical heterogeneity in HOCM is extensive and manifests as variability in symptoms and the progression pattern of the disease, the age of onset of symptoms, the incidence of arrhythmia, the magnitude and pattern of hypertrophy, the histological extent and the pattern of hypertrophy, and the predisposition to heart failure, and ultimately the incidence of sudden cardiac death. This variability has led to controversy surrounding the validity of both clinical and genetic parameters as risk factors for sudden cardiac death and HOCM. To date, the main clinical utility of genetic testing has been in redefining the range of clinical features and natural phenotypes and natural history of HOCM. In particular, genetic testing is being applied in severe disease state and atypical phenotypes or to unrevealed phenocopies of the disease. Moreover, genetic testing aids in identifying genotype positive, phenotype negative family members when a molecular diagnosis of the disease has been established in that particular family. Today, there is no unifying hypothesis for the pathogenesis of the disease. The energy depletion hypothesis, although interesting, does not explain why certain individuals with HOCM progress to overt heart failure, where the majority do not. Moreover, it does not answer the dilemma why certain patients are at increased risk of sudden cardiac death compared to others. There is no definite curative treatment for HOCM, rather that current treatment focuses mainly on treating symptoms, mechanical obstruction, and the prevention of sudden cardiac death. There remain a lot to be explored and devoted for the in-depth understanding of the molecular basis that's responsible for the progressive LV remodeling and systolic dysfunction, and the subset of patients who progress into the advanced stage of the disease, whereas the majority don't. Also, with improving technology, one may expect to see direct application of genetic testing, which is currently a laboratory undertaking, into the clinical service setting. This type of bench to clinical transition has the potential to aid the clinician in the better management of the disease in the form of individualized medicine. There are currently no randomized controlled trials that had head-to-head compared septal myectomy versus alcohol septal ablation. These types of trials are very difficult to conduct for multiple reasons, but most importantly for ethical reasons. Thus, there remain multiple areas to be investigated in the whole spectrum of the disease. We look forward with optimism and enthusiasm for the future. Thank you for your attention.
Thanks very much, Antoine. Great manuscript. Very nice indeed. Well, today we have with us a visiting professor who has been recognized by everybody as one of the best teachers today available in the world in the cardiovascular field. It's Dr. Nishimura, who I met him first when he was a fellow at the Mayo Clinic, and we were able to work, both of us, for a number of years together. It's a privilege to have him as a visiting professor today here at our medical center. So I will introduce Dr. Nishimura very briefly. He's a consultant at the Division of Cardiovascular Diseases at the Mayo Clinic, professor of medicine, and he has the Jude and Mary Morris Layston Professorship at the Cardiovascular Diseases and Hypertension at the Mayo Clinic. I cannot say he was born in New York this time. He was actually born in Chicago. And he attended Knox College, where he began to have all the awards available in that college in the Chicago area. He obtained the MD degree at Rush Medical College. And then he had his internship between Rush Presbyterian and Chicago and the Mayo Clinic. And then is when I met him, he actually was a fellow, became a fellow at the Mayo Clinic. And he has been there since with the titles I mentioned. Now, it is quite striking, his educational assets. I mean, he got the 4 awards in college. Then he was at Rush Medical College and got also 4 awards. And then at the Mayo Clinic, it's outstanding, he got the Best Teacher Award for the last 12 consecutive years. This is very boring, though. I mean, you don't give a chance to anybody else there. You know, he's unbelievable. And then he has a Hero Award from the Association of Black Cardiologists, the ACC Gifted Teacher Award, actually of the American College of Cardiology about a few years ago. He has been very involved with the American College of Cardiology. He is in the Board of Trustees. He's in the Task Force of Guidelines Committee and in many other educational committees of the American College of Cardiology. He has been certainly one of the most seeked individuals in terms of invitations at the national and international level. And he has about 300 papers in high peer-reviewed journals, which really touch into every aspect of cardiovascular diseases. I mean, he's just not a great echocardiographer. He's just a great clinician and with a great judgment. And many of the complex patients that are around the world are seeking his expertise at the Mayo Clinic. So Rick, it's a pleasure to have you here today, and the fellows, what I've heard, they enjoyed tremendously your visit for a few hours that you have been with us, and I'm going to give you this for you to remember, this plaque of the plaque. It seems more meaningful than the check. This is for your pocket. And it's the faculty really expressing our appreciation for your visit here. And Andy Sharma, visiting professor, and Simon Duck Memorial Lecture. Thanks for being here. And now you're going to be sitting here in the middle, and I'm going to call the other experts to address the issue of hypertrophic cardiomyopathy. I think Laurie Croft cannot be here. Martin, I think you should be the echocardiographer sitting. Robert Lesnick, as we said, Dr. Kinney, Mark Miller. Paul Stelzer is not here, but we have the chairman of the department, Dr. David Adams. Hey, David, yes, you'll be here. And then, of course, Antoine. I don't think I forget anybody, did it?
Very good.
Yeah. Let me see how many people are here. Sure. Jose, you want to come? Where is Jose Melo? Yes, yeah, sure. Get another chair.
Yeah, Robin's going to take my spot.
No.
Robin's going to say it.
Oh, Robin?
Yeah. Hold up the chair.
Okay, that's a great chairman. Good. Well, anyway, the subject today is, I think, is a very it's a complex one. Every year we learn new things. But I would like to start with you, Rick, about the issue. We have 2 aspects on hypertrophic cardiomyopathy. One is the genetic aspect, and the other is the hypertrophic aspect. But it seems they're not going always together. I mean, we have a number of patients, actually, more than 50%, in which genetic evaluation is being done and one finds nothing, and they have significant hypertrophy. And on the other hand, there are a number of people that are being discovered more and more that have the genetic trait and they do not develop hypertrophy. Is this part of the complexity of this disease? I'm just talking in general, Rick. The genetics and the hypertrophy, they really are not completely linked one with the other, although it's an autosomal disease. We know that.
No, absolutely. I think in every aspect there's an incredibly wide spectrum that we haven't found the connection. And there are patients who have the terrible prognosis who might only have mild hypertrophy or no hypertrophy whatsoever with positive genetics. There's other patients who have severe massive hypertrophy who will live a long life and might not have any identifiable gene seen. So we do not have all the answers at this point in time.
Okay, Martin, you are in the ECHO lab, and we are told that 1 in 500 people have hypertrophic cardiomyopathy. I believe this is probably an underestimation of what this is all about. I suspect this is much, these are people who show up, but many people carry the diagnosis. Actually, we see them in the elderly age. It's not correct. So 1 in 500 probably is a figure that comes from institutions that see these patients, but I suspect it's much larger than that.
Yeah, I think that there's a spectrum. You have, when you do screening, you have athletic heart, you have other infiltrative diseases and hypertrophic cardiomyopathy. But I think that the 1 in 500, may be conservative, particularly with better imaging techniques we're seeing in the elderly. Apical hypertrophy, besides the classical basal hypertrophy, which was the marker of the disease before we understood that it can present anywhere in the ventricle at all.
Jose, one of the problems with this disease is not the 70% group that have obstruction of the left ventricular outflow tract, but the 30% group that have no obstruction, and how you distinguish this from the athlete's heart. What is your feeling about that?
Well, there is an overlap at some point between 12 to 14 millimeters of ventricular wall. It could be due to an extreme athlete who's doing a lot of exercise, and if that person would stop exercising, we would hope to see regression of that after 3 months. 15 and over, or maybe 15, 16, but 15 and over already becomes part of the real illness. You don't get to those higher levels, let's say, with just plain exercise. Now, the prognosis of the athlete is good. The prognosis of the other one may be not as good.
We might touch on this later. Yeah, but certainly it's just to define that 30% of people is not so simple to say whether it's hypertrophic cardiomyopathy or not. Now, Bob, about the genetics of the disease, I still remember maybe 15 years ago, there was like a single gene is affected by hypertrophic cardiomyopathy, and I remember people going around the world talking about. Now today it seems that we are 11 genes have been involved with about 1,400 kinds of mutations. This is really leads us to become a little bit skeptical, because you may have a mutation and you don't have the disease, or you might not have the mutation of these 11 because it's an identifiable and you have the disease. Just as a real expert in genetics, tell me what has been in your mind in the history of genetics in hypertrophic cardiomyopathy, because it seems it's at a moment in the lows at this time.
Well, you see the tip of the iceberg and you recognize the patients, and then you identify some of the genes that are involved. And now laboratories in the country, there are 4 laboratories that are testing not just for the old 11, but now for 18, and there are many, many more that have been discovered. And of course, these are big genes, they're sarcomeric genes, so they have lots of opportunity for different mutations, so it can almost be family specific. And what the next step really has to be is to take the most common mutations and very careful phenotyping and be able to distinguish those that are going to have the different outcomes so that you can do genotype-phenotype correlations. And in the future, because it's a dominant disease, you're going to have to be able to have some predictive value. You just can't say, the prophecy is that you're going to have that mutation and therefore you're going to have a bad outcome. And just recognize that there are 25,000 other genes, and probably there are thousands that contribute to heart function and structure. And if you're at all heterozygous for any of them, it may alter the autosomal dominant phenotype. So this is a disease that's just waiting for a very, very clear delineation where we can begin to understand the complexity. And I think that's kind of the history, but the future is going to be more complex because we're going to be able, and it probably will be in the next 5 years, the cost of sequencing your whole genome, or at least the business part of it, which is about 1.5 or 2%, is going to come down to be so inexpensive that you just don't do targeted sequencing for HOCM, but you do whole genome sequencing or whole exome sequencing, and now you're going to pick up a host of mutations that you really have to link in a network to understand the complexity of the disease. And that's going to be challenging, but those are patients who actually have it. Now, you're going to be doing sequencing for the entire population because when personalized medicine comes in the next 5 to 15 years, 5 is optimistic, 15 is probably realistic, you're going to pick this up in babies. You're going to pick this up with newborn screening. You're going to pick it up for other reasons. That's why it's so important to understand the genotype-phenotype correlations. And from a geneticist point of view, this is a gold mine of work to do.
Bob, I have 2 questions about this since we are into the genetic aspect of the disease. The first is, we see a number of people who we believe have hypertrophic cardiomyopathy, and they are in their 60s, and they have a history of hypertension. Do you think this is like a low penetrance and the hypertension triggers it? Because what I'm really driving is probably not one gene, it's a combination of genes that may lead to the disease with the environmental factors that make a gene to be active or inactive, and just which adds to the complexity. Is not one of the issues.
So I agree, because this is sort of like hemochromatosis. It's 1 in 10, but how many really get the disease? So having the gene doesn't do it. And I think you see that you pick up many patients who test gene positive when you send it off to the laboratory, but yet their disease is different than other people who have the same gene but different defects in the gene. So you can look at it in the following way. If you have a particular gene that's involved in HOCM, you can have a whole variety of mutations. Some of those mutations may give you residual function. So those patients are going to be milder. Others are going to just knock out the gene function, and those are going to be more severe. So you have to look at the type of gene defect. But then what Valentin is saying is, Dr. Fuster is pointing out that you can have really multiple other genes that interact with cardiac function that are going to either modify it, and we call those modifying genes. They're either going to make it milder or more severe. So I think it's going to be very complex.
Okay, Antoine, going into who I test for genes in hypertrophic cardiomyopathy, and I think you come out that there's only one justification, and the justification is somebody who already has the disease. The gene has been identified, although there are always questions, and the family wants to know whether or not they are going to develop the disease or not. This is the only case, or the most important situation by which you might test it. You already tested in somebody for whatever reason, because you want it, let's say, and then you go into the rest of the family. Is this the only case that you see is important, or what is your feeling about it?
That's not the only case that it's important. Well, if you want to see family members who are genotype positive, phenotype negative, then you pick up the proband that has the typical features of HOCM that you think, and then you run a genetic testing on that proband to develop a molecular diagnosis of that family. You cannot pick up any type of mutation. The mutation that you're going to be looking for are the mutations that are very well known to cause the disease, such as the myosin binding protein C3 or the beta myosin heavy chain 7 particularly. And this is not the only way, the only time when you do genetic testing. You also do genetic testing in cases where you think the patient has HOCM, but you're not that sure whether you know there is a malignant course of the disease with rapid progression to overt heart failure, or you are in doubt that this is an atypical case of HOCM, or you know you have to rule out phenocopies of the disease, such as patients with LAMP2 deficiency also develop hypertrophy.
Well, Bob, can I, because I disagree with that. I want to get into this. If I want to know if a patient had HOCM or not, to do genetic testing, you can end up absolutely confused about it. I just like to make your comment, because if we start doing genetic testing with all the variations we already talk about, the misinterpretations, the number of mutations, how in the world you can end up making a statement that whether the patient has HOCM or not?
We'll toss that up and see who's going to field it.
Yours.
Oh, so I know the least about the disease, but I know a little bit about genetics. If you have well-documented mutations that are common, then you pretty much know that that is going to be HOCM, and how it's modified is another issue. If you're doing whole gene sequencing of these 18 genes, and now that's the trend, we use next generation sequencing, you're picking up not only the mutations that are well known and described in other patients, but you're also picking up mutations that we say are of unknown significance. And then the only way you could verify it is, of course, if you made a mouse or did some research on that to understand how it affected sarcomere function. My preference would be, as a geneticist, to do the tests on all patients that are suspect HOCM, because you will find that there are those in which you will detect known gene mutations. It will influence how you manage that patient and the family. In addition, you may pick up other diseases that are treatable. The reason they invited me is because I deal with Fabry's disease, which presents with left ventricular hypertrophy and leads to hypertrophic cardiomyopathy. If you go to one of the U.S. testing companies and you ask them what % of patients that are thought to be HOCM, it turns out that 3 to 4% are unrecognized Fabry that's treatable. So gene testing provides that kind of information. And of course, I'm biased because we developed the treatment for that disease, and you know, if you get it early enough, you might be able to alter the course of the cardiac manifestations.
Well, Rick, you know, I have great problems with this. I mean, if more than 50% of HOCMs have negative genetics, how can I know if I do the testing and it's negative, I don't have HOCM? In other words, this to me is really getting into a field which is extremely, can be very relevant to develop an anxiety situation, because you cannot tell. Even if it is positive, unless it's one of the two most important genes that he mentioned, you cannot say you have HOCM. I'm just trying to say that...
Well, HOCM's such a heterogeneous diagnosis anyway that you can say you have autosomal dominant hypertrophic cardiomyopathy, what you're trying to do is pin it down to a particular genetic defect. You can't do that at this point.
Yeah.
We agree.
Okay, let's now move into imaging. It's interesting. I mean, the story of imaging in IHSS is by the way, we call IHSS, and it has 70 nomenclatures in the world to describe this disease, which is interesting. One is IHSS, but there are many others. But let's go into the history of IHSS with echocardiography is quite relevant, but it seems to me that MRI is giving to this disease much more complexity. I'd like to ask both of you, first you, Martin, about echo versus MRI, and then you, Rick, also to give us your view about the importance of these two technologies. Martin, you're first.
Yes, and Javier Sanz is our expert and really contributed significantly. I think imaging now is a combination of the two. I think the echocardiography tells us about the physiology regarding where is the wall thickness and if it's a dynamic obstruction or not. And I think what we're learning from the MR is whether there is abnormal myocardial architecture, which can be interpreted, it's not necessarily scarring, but abnormal myocardium, which the more myocardium that's abnormal, Barry Marin feels very strongly is a risk factor for sudden cardiac death. Whereas echocardiography can't distinguish. They can just look, we can just look at the thickness. We can sometimes even miss some of the anterolateral wall unless it's done really carefully. Some of the areas which MR can pick up. So I think that when you suspect a patient hypertrophic cardiomyopathy, I think doing both imaging tests is additive and provides prognostic information rather than just a single test. The addition of use of stress testing, I think, is also very helpful to bring out both arrhythmia as well as to provoke gradients in patients, which has prognostic implications potentially, particularly if you're looking at symptomatology.
Okay, Rick, both technologies?
Well, I guess in the era of cost containment, we have to be careful about the number of testing that we order. And certainly echo would be the primary diagnostic tool of choice. Now, what an echo cannot do is in the equivocal cases, MR can see areas of hypertrophy that might not be visualized by echo. It can give some additive information about the presence of, for instance, apical pouches, which put a patient at high risk for sudden death. But I think its major goal, as Martin has said, is the visualization of gadolinium enhancement defects can identify patients at high risk for sudden death. But I think what we can do is we can probably risk stratify before we get to ordering an MRI scan, because we know that it is mainly the young patients. It's the patients with family histories that are going to be at highest risk for sudden death. So whether you actually need to do MRI scanning in your older patients, in patients without a family history, and in patients without significant hypertrophy is probably up in the air.
Okay, it seems that what MRI has given is a sense also of the complexity of the disease by localizing the areas and the degree of hypertrophy in a tridimensional mode, maybe more accurately. Yeah. Jose, I go back to you about the athlete's heart now. We have a patient today, actually, who came to see us because of the possibility of hypertrophic cardiomyopathy. And there has been a lot of question about it, but there's one thing that was interesting is like an athlete who doubled the exercise program in the last 2 years. And when you look at the echocardiograms 3 years ago, interestingly, the degree of thickness, particularly at the apex, is much less than the degree of thickness that it is today after has been overexerting. And one of the issues to make the differential diagnosis is to have an athlete to become deconditioned and have the hypertrophy to decrease. I think this is nice to talk about it, and certainly the patient today came to my mind like a possibility, but what other aspects are? It seems to me that hypertrophic cardiomyopathy has so many irregularities, the thickness of one focal area, not another, and so forth. The chamber is small. I don't think it should be too difficult, isn't it, to distinguish one versus the other?
Well, in theory, an athlete's heart should be concentric hypertrophy and not asymmetric or apical. It should be everywhere. And however, we see once in a while patients who lift weights who have excessive septal hypertrophy more than the posterior wall, but still within the, let's say, normal ranges. It's extremely difficult to really distinguish when it's a 15 millimeter ventricle thickness of the wall, concentric in a major athlete, to know what it is, because that's exactly the overlap area. And in theory, because we have seen actually ourselves, we have seen soccer players, professional soccer players, who have this type of, who exercise beyond their exercise for the game, who have a 15 millimeter concentric hypertrophy. And once in a while, because we cannot tell them stop playing, I mean, it's not realistic and they are not going to do it, we do once in a while an MRI to see if they have really any fibrosis, which usually they don't have at this level, and then we reassure them and we let them play. Because the question is sudden death, if those patients are exposed to sudden death or not.
Okay, well, I guess it's a lot of judgment, isn't it? But the disease, it appears to be much more homogeneous, the heart of an athlete than the other. Well, this leads now into the family screening, and the question that we will get very soon is into the issue of sudden death. Mark Miller is so anxious looking at me for the last 20 minutes, but you will see, I will get into you. Don't worry about it, Mark. Let's get into the issue of the family screening. It seems that, Antoine, you mentioned what the guidelines say, that we should screen if you have somebody in the family who has hypertrophic cardiomyopathy. You do this from age 12 to age 18, and you do this on a yearly basis, because that's the time which is the most dangerous time of the disease. Is this correct?
Well, usually the manifestation of the disease comes with the growth spurt that you have. So in most cases, the penetration of the disease, those who are genotype positive but not yet have the phenotype, usually they become phenotype positive in the first, between age of 12 to 21 years. That's why we do
hypertrophy.
Mm-hmm. That's why we do imaging mainly by echocardiography every 12 to 18 months. However, there might be penetration of the disease, penetrance of the disease in earlier age, but these are rare cases. And the only indication is to do imaging is when you suspect that there is hypertrophy, or you suspect that that there is a malignant family history of the disease, then and the child is coming and you suspect the disease, then you do the imaging.
To do it earlier, but also later, every 5 years.
You should continue screening until midlife. Because there is late penetration of the disease, but you do less frequently. After the age of 21, you do every 5 years, unless there's change in symptoms, or you suspect that there are new symptoms that's coming, and you suspect that the patient has developed hokum, then you do earlier screening or more frequent.
Well, let's now get into how the disease gets manifested, and there are actually 5 aspects that we are going to discuss one by one, because each of them has therapeutic implications and prognostic implications. One, of course, is sudden death. The second one has symptoms of left ventricular failure, which could be related to obstruction or related to diastolic dysfunction. And then the third one is atrial fibrillation, more with obstruction than the other. And of course, with atrial fibrillation is the issue of systemic emboli. So in fact, we touch into the 5 issues that now we have to really focus our attention to. Now, Mark, let's begin with the issue of sudden death. I remember when I was a fellow like Antoine, there was a panic when you saw, remember, Rick, we saw so many patients at Mayo with hypertrophic cardiomyopathy. It was like a panic. We all thought automatically that that patient was prone to sudden death, and that's the reality. Now today we have learned that the incidence of sudden death in hypertrophic cardiomyopathy is almost similar to the average population. So I like you how you react to this. We are now beginning with general comments about sudden death.
So I think you're correct. I mean, the reality is a lot of patients walk around or they get referred with a diagnosis of HOCM, but the incidence of sudden death in HOCM, especially without any risk factors, is about 0.5% or something around that per year, which is high for the individual but low in the grand scheme of things. And you take, you can add up the risk scores. You can take 1 risk factor, 2 risk factors, 3 risk factors, and we generally recommend ICDs for patients with 1 or more risk factors. But the difference between 1 risk factor and no risk factor, the difference between a risk of sudden death per year, about 0.5% versus 0.65%, which is not that dramatic. What's interesting is that when patients get referred, the referring says, well, they have HOCM, so they need an ICD, which is not always true. The other aspect of looking at it is the fact that patients or referrings or physicians will often say, well, they have a septum of 25. They absolutely need an ICD, and that's not correct either. You have to pick your threshold for where you feel comfortable putting in a primary prevention ICD. Keep in mind that everything comes with a cost. When you put an ICD, especially in a young patient, there's a cost associated with that. There's the short-term and long-term complications associated with ICD.
Yeah, we'll talk about ICDs in a moment, but I think the issue is that this is not so common as people thought. You think, Rick, this is because the institutions who reported the disease are institutions who were really getting the patients. In other words, it was a selective situation and only the sick patients were seen in those institutions.
Oh, absolutely. It was Bill McKenna and Celia Oakley back in the 1970s and the NIH that had all of these high-risk patients sent to them because that was the methodology of diagnosis. What's happened now is we're diagnosing the asymptomatic patients and finding out, as Dr. Fuster said, the prognosis is actually comparable to that of the age-matched, sex-matched control population.
Okay, let's go into the risks of sudden death. This is what we are talking about. And I think there is a lot of common sense to start with, syncope, recurrent ventricular tachycardia, death in a family at a young age. All of these things, I think we all know about it. And then you add 2 anatomical aspects, which is a septum of more than 30 millimeters. I'm just talking about guidelines. And the other is the delay enhancement, which is becoming more than 20% of the ventricle being fibrotic. Rick, how do you feel about all of these? Do you think you can identify the people who are really prone to sudden death? There are other aspects like a very significant gradient and so forth, but I'm just talking about the key ones.
I can tell you there's a number of patients we've had who've died suddenly without any risk factors whatsoever, so we're never going to be able to identify them all. But I think one of the things that we actually didn't stress enough in the guidelines is that it's the age of the patient that's probably the most important when making your decision. So for instance, in our own data, we know septum of 30 millimeter is a terrible thing, or syncope is a terrible thing in a 25 or 30-year-old. But if you have the same anatomy and maybe the same symptoms in a 65 or 70-year-old, they're probably not going to die of sudden death. So I think the clinical aspect is very, very important on using age also to tell you in addition to these other risk factors.
Now, what about the issue of the gradient, which has been very debated, because there is a movement at the present time in doing a procedure with the gradients of more than 50 millimeters of mercury, thinking that this is one of the causes of sudden death. If you are dealing with a relatively young person, is this something that you take as a risk too? Because this is new, or is more recent.
Yeah, there is no data to say that decreasing the gradient is going to prevent risk of sudden death. I do think, however, and this is from very limited data, that surgical reduction therapy will not eliminate sudden death. But in the patients who've had an adequate surgical reduction therapy, their sudden death incidence is dramatically decreased.
Mark, we talk about the risks, and obviously we didn't talk about the secondary aspect, somebody who already had an episode of sudden death and was resuscitated. But when you go into the issue of the defibrillators in these patients who are at sudden death, what about home defibrillators? Would you put a defibrillator in the home of an individual in which the family is affected by IHSS? What is your view? I can tell you that in the literature they say it's no cost effective, but whatever it is, I'd like to know what you think.
As a long-term treatment option?
Yeah.
No, because I don't think it's effective, and patients dying during sleep, and you can't always expect a family member around. I don't think it's cost effective. I don't think it's clinically effective to have an external defibrillator around all the time. I just have one question for Dr. Nishimura, actually, about the concept of doing septal reduction therapy as bringing a patient back to baseline. Do you reassess the patient's risk for sudden death?
We would assess them before the operation. If they're at high risk, we would implant the defibrillator irrespective of the operation.
Rick, since we are talking, we talked before about the two anatomical issues and MRI. Right or wrong, when I see a patient who doesn't have the risk factors that are the conventional ones, I do two things. I do an MRI for delay enhancement, and I do a Holter monitoring, if I can, 48 hours. Do you think this is appropriate or is inappropriate?
I think that's very appropriate. I think the emerging data now is going to show that the delayed enhancement on MRI scan is going to outdo any of our other conventional risk factors for prediction of sudden death.
Okay. Well, we are now getting, Robin, we are getting closer and closer to you. Now we discuss outflow obstruction, and in the context that we discussed were two contexts. One is symptomatology. One of the main issues is shortness of breath in patients who have significant left-sided outflow obstruction. And the other was that we touch into the possibility that a significant gradient may predispose to sudden death. So now is the moment that we have two options, either to call a surgeon or to call an interventionalist. Now, how do you react to that, two possibilities? The surgeon is to do the surgery, and we'll talk about what kind of surgery, and the interventionalist is to use alcohol and into one of these septal branches and to see what goes on. And I'd like to know your opinion before we go any further.
If we look at the current data, there's no level A evidence with randomized trials comparing the two, but there's been a lot of meta-analyses that Antoine's nicely alluded to in his manuscript there. I think surgery provides three main benefits over alcohol septal ablation. Number one, there's been a number of meta-analyses that show that the gradient is lower after an appropriate and proper extensive myectomy. So what Dr. Nishimura alluded to, which is that you have to do a proper septal myectomy where you're resecting a large portion of the septum, and it has to be aggressive. So we have lower gradients. Now, whether that translates into some improvement from a symptomology standpoint, we're not sure. Secondly, I think more importantly, the incidence of heart block requiring a permanent pacemaker is lower with surgery, just because we can be very precise to avoid the right bundle. We'll always give someone a left bundle after septal myectomy, but if you don't have a right bundle, it's very unlikely that you'll need a pacemaker. And I think, if I think back to the number we've done here with my senior colleague Paul Stelzer, who's taught me most of what I know about the surgical resection, we've had very low incidences. I can't even recall one patient that's required a pacemaker. So those are the two main advantages, I think. There have been some data looking at the incidence of arrhythmias with alcohol septal ablation versus septal myectomy. And then we have a small percentage of patients that have primary SAM associated with HOCM, which surgically we can address by looking at the abnormal chordal attachments and abnormal papillary muscle attachments that come across the outflow tract that we can resect as well. So I think in younger patients who don't have contraindications for surgery, there is some benefit to surgical resection. In the older patients, the risk might be slightly greater, and alcohol septal ablation, I think, is an option as well.
So in fact, what you are saying is that for a younger patient to consider alcohol ablation is probably out of the picture. For a very elderly patient with comorbidities and so forth is a possibility, which I agree. I'd like to give the latest figures of meta-analysis done on the alcohol ablation, which I think are important. First of all, the amount of myocardium that becomes an infarct with alcohol ablation by magnetic resonance imaging is an average of 10%, which is very significant. Second, the need for pacemakers is, depending on the institution, is between 8 and 15%. Third, the issue of ventricular tachycardia, the issue of mortality with alcohol ablation is 2%. And finally, the incidence of ventricular tachycardia within the first month, which can be fatal, is 3%. So I guess, Rick, I go along with Robin, and that is I wouldn't touch a young person with alcohol ablation unless there are significant pressures for whatever reason, and I would consider this for more of a elderly population. Do you have a different point of view? Is Mayo doing things different?
No, it's a shared decision-making process. You offer both options. You tell them the pros and cons of each. I can tell you that of 200 patients that came in the last year and a half, 4 out of 5 of them chose the septal myectomy, and they were very, very happy with the results. There are some patients who say, "Doctor, I'm never going to want surgery. Please do the alcohol ablation," and we'll do it with the caveats that we spoke about. But overall, the results of an experienced surgeon doing a great myectomy is wonderful, and these patients get back to a completely normal lifestyle.
Okay, Jose, any comments?
No.
Martin?
Rick, because Barry Marin feels that the septal alcohol ablation actually increases the risk of sudden cardiac death by creating a new substrate for ventricular tachycardia in a very arrhythmogenic heart.
Well, we have no data that confirms what Barry says, but we do know this, is that the centers that use a large amount of alcohol get the best hemodynamic results, but they also have the largest incidence of ventricular arrhythmias. The centers that use small amounts of alcohol deny an increased incidence of ventricular arrhythmias, but they are centers that do not achieve the excellent hemodynamic results, and many of their patients end up at Cleveland Clinic or Mayo Clinic for the surgery.
Okay, so, yes.
I'm just curious, when we see a lot of patients here who have mid-ventricular obliteration or the obstructions, and what's your approach to those, even surgically?
So there are a group who do develop mid-ventricular obstruction, and I think in following the natural history, there are patients who may have started out with severe apical obliteration, and then due to the high wall stress in the apex have developed an apical aneurysm with mid-ventricular obstruction. One of our surgeons, Hartzell Schaff, has approached these from the apical route, in which he'll go in, he'll do an extended myectomy from the transaortic route, and then slice through the apex and remove the mid-ventricular myocardium from the apex through a ventriculotomy, sewing back out the apex. And it's been very, very effective. We've done over about 60 of them now with excellent results from the hemodynamic and symptomatic standpoint.
I saw that paper presented at the STS. They presented their series, which was quite impressive.
Yeah.
The only thing, we were talking about considering that option here, because sometimes we end up with very small aortic annuluses, and that's really sometimes makes the operation difficult because it's very hard to get to that apex, especially when you have these apical aneurysms and a very thick septum all the way down to the base.
Absolutely.
And so that technique sounds very effective, but then we were wondering whether there would be an increased incidence of arrhythmias after they've done the ventriculotomy, and I wonder if you can comment on that.
We haven't seen an increased incidence of arrhythmias, but there are a couple patients now who have returned maybe 5-10 years later who've started to develop the dilated phase. So we don't know if it's their natural history or there's a propensity to that, but it's something we need to follow up in the future.
Rick, can I ask you, I want to touch for a moment into a syndrome which is actually 30% of the patients with hypertrophic cardiomyopathy, which is the non-obstructive disease. So let's concentrate there. We talk about the athlete's heart, but I'd like to touch into something else. First, do you think there is a relationship between the non-compaction left ventricle with a type of cardiomyopathy, which is a hypertrophic one without obstruction? Yeah, I'm talking only on clinical basis. Then I will ask Robert.
No, absolutely.
Tell us.
There's probably about 10% of the patients with a non-obstructive hypertrophic cardiomyopathy who have the very prominent trabeculations, and some of them actually even fit into the criteria of non-compaction. So I'm sure that there's some type of a link between the two entities as they develop in utero. But we've certainly seen the association of the two together.
Okay, Bob, can I ask you about with these patients with no obstruction are the ones that sometimes we get trouble with Fabry's disease. Can you tell us how do you view this?
To me?
Yep. You're an expert on Fabry's disease, and I'd like to know, because this 30% is always a little bit of a struggle.
So here we're treating patients with the enzyme they're missing, and our experience is that if you start early enough, you can achieve some gain. And in the later patients that were treated first, because they were most severe, particularly those with HOCM, they benefited for a year or two. They had some reduced size. They also have the basolateral infarcts and fibrosis, and those do poorly and end up with a ventricular attack and succumb to the disease. I think the question that I would turn around is something like this. If we have a treatment, if we could start early enough with this slowly progressive disease, we may be able to minimize or prevent it. And the question comes, what is the most sensitive way of detecting the change before it happens, before you see the hypertrophy? Do you do speckle tracking? Do you do strain rate? Bring a geneticist up to date with the latest technology, because we'd like to be able to intervene early in those who are going to develop significant cardiac disease or have the propensity for it.
Yeah, but my question is Fabry's disease.
Yeah, I'm talking Fabry's. Because there we have a treatment.
So this is perhaps one place where genetics are critical.
Say it again?
Genetic testing is critical to distinguish between the hypertrophic cardiomyopathy of a restrictive type from Fabry's disease. That's what I was driving at. That when we talk about genetics, this is a clear example.
Well, here it's rather straightforward in terms of, one, you have X-linked inheritance rather than autosomal dominant, and number two, you have one particular gene with well-known mutations. So you know the severity of the mutation, and you can either predict that it's going to be a classic mutation, classic not in the sense of HOCM, but in the sense of Fabry, and you know that they're going to have severe kidney and heart disease. On the other hand, many of the late mutations, which are later onset mutations, which are picked up in screening for HOCM, where Perry Elliott and McKenna first said that 5% of the males had it. We don't believe that anymore. It now looks like it's about 1% or less. So if you screen in general all your HOCM patients, you'll probably pick up 1% that have Fabry's that's treatable. There, I think the importance is early intervention. And I was going to sort of turn it back to the genetics, and I'm glad you did, because in HOCM, you have a family where you have 3 generations where the grandpa died early, the father is ill and not doing well and has had some myectomies, and now you have the young boy. And the young boy wants to know, well, first of all, he's gene positive. What's his future? And I think early detection here will play a role in monitoring, and I think it relates particularly to Fabry's because we can treat it, and the earlier the better.
Good.
So what are those methods?
Yeah. Anyway, another issue now is atrial fibrillation and systemic emboli. The figures are that 20% of patients with hypertrophic cardiomyopathy develop atrial fibrillation, particularly those with the obstructive disease. And the incidence of a stroke cannot be followed with the usual CHATS method. It's completely erratic and actually unpredictable. Is this the case, Rick, you think?
Yes. You cannot use the CHAD score in the hypertroph because they are at a very increased risk of embolic events with atrial fib.
Yeah. So these are patients that you have to treat, obviously, with antithrombotic therapy.
Yes.
But one of the things that is quite striking, and this is in the literature, is that we always thought that a patient with restrictive disease or hypertrophy in which develops atrial fibrillation, things get much worse, when in fact it's not the case in the majority of patients with hypertrophic cardiomyopathy. And the question is why you decrease the gradient by not having the atrial kick, and maybe the hemodynamics get better. What is the explanation for that? We have a number of patients with atrial fibrillation who actually got better with hypertrophic cardiomyopathy. What is the mechanism?
Can you repeat that again? I was following up.
Yeah, there is a literature about atrial fibrillation in IHSS.
Correct.
And all of what we think about patients with hypertrophy is that when you develop atrial fibrillation, the patient gets worse because of the lack of the atrial kick. But this is not the case in obstructive cardiomyopathy in many cases. And I'm asking, what is the mechanism? Why not?
I think in those patients, though, with obstruction, they can get dramatically worse if they go into atrial fibrillation by losing the preload and increasing the obstruction. However, what we've seen is a number of patients who've lost their obstruction, who then develop atrial fibrillation. And what has happened there is that their atrial contraction has been very, very minimal when they're in sinus rhythm. So they have what we term in Doppler, and Martin would know this, early restricted filling, in which all of the filling is in early diastole, very little is in late diastole. So actually when they go into atrial fibrillation, they don't even know they're in atrial fibrillation. Okay. I think that's the population you're talking about.
Now, Mark, atrial fibrillation radiofrequency ablation, what do you think in a high HSS?
I think the results are not as good as with the regular paroxysmal AF patients. And one of the reasons, I had one question which I'll get to in a minute, but I think one of the reasons may be is that you have to keep in mind, in order to get permanent pulmonary vein isolation or durable pulmonary vein isolation from a catheter ablation perspective, you have to get transmural necrosis or transmural lesions, and that's more difficult to do if the thickness of the left atrium, if the diameter of the left atrium is thicker. So I think it's more difficult to get durable PV isolation. I think they're also more prone to post-ablation arrhythmias in that sense. The one question I have for Dr. Nishimura is, why are the patients with AF at higher risk for stroke compared to other AF patients? I know we can't use the CHAD score, and almost the recommendation is universal anticoagulation, but what's different about their left atrium or about their left atrial appendage that puts them at higher risk for stroke?
I have no idea.
I would say, if I may, maybe I'm wrong, but the patients with hypertrophic cardiomyopathy, they have a very large left atrium.
Yeah.
And that's probably the reason. In fact, when we were talking about the athlete's heart and the hypertrophic cardiomyopathy, one of the key aspects on imaging is the size of the left atrium, which is very large in hypertrophic cardiomyopathy, maybe normal in the athlete. And I would, at least I assume, right or wrong, that that's the reason why thromboembolism is more predominant.
The one last question I had is, obviously patients with HOCM are predisposed to developing atrial fibrillation. They have relatively high incidence. Do you know anyone that's doing, when they're doing a surgical septal myectomy, is also doing mazes at that time, or
Yeah,
at least pulmonary vein isolation, the prophylactic measure?
So not prophylactically, but in the last 3 to 4 years, both of our surgeons, if a patient has had symptomatic atrial fibrillation, either paroxysmal or persistent, they'll do a surgical maze at the same time. And they haven't gotten into trouble like the initial Jimmy Cox data says because you lose their atrial contraction. They've actually done very well in terms of hemodynamics.
And maybe I can ask Robin just how much additional time that adds to a septal myectomy.
They're just doing pulmonary vein isolation would add just probably 10 minutes to the operation. We're doing the same for patients with atrial fibrillation. If they don't have any atrial fibrillation, then we don't, but we take the left atrial appendage off in all patients in this group.
Dr. Adams, you have a question.
Rick,
Can you use the microphone?
Thanks.
Yeah.
Rick, can you distinguish for us this subgroup with mitral regurgitation? So, we see two different types. So this group that just has primarily it's the gradient, but then the second group, and I don't know whether this is a genetic problem with the mitral valve or whether it's just lived in the outflow tract long enough that the anterior leaflet is contracting, but we see a lot of abnormal connections to certain valves. So I know Hartzell's bias is to do the myomectomy first, come off, then see whether that's resolved any regurgitation. We've had a little bit different strategy where if we've had severe regurgitation, then we tend to explore the valve on both sides. Paul will do the myomectomy and I'll look at the mitral valve. But what's your sort of current view? Are these different diseases or different phenotypes, or is this just cause and effect?
I truly believe that hypertrophic cardiomyopathy is a disease of the mitral valve apparatus as well as a disease of the myocardium. And they've got displaced anterior enlarged papillary muscles. Their leaflets are markedly elongated. They have abnormal insertions. So that all leads to significant mitral regurgitation.
Yeah, and I think that's for you guys that are taking care of patients, in my mind, that's a very important discriminator when you're thinking about alcohol ablation. I think if you have moderate or severe regurgitation, I think it's much more likely that you're going to do better with surgery because you have an opportunity to address the mitral malformations in a much more straightforward fashion.
One of the striking things is that by looking at all the anatomical patterns of hypertrophic cardiomyopathy, it's amazing what happened with the chordae tendineae, with the leaflets of the mitral valve, lots of different, that I'm sure may have different genetic reasons for, as you say, the mitral valve may be involved too.
Your point's really interesting. It's not made that commonly, but you're absolutely right about the anterior papillary muscle and the connections to the mitral apparatus. That's something that we see all the time, and it's interesting that it's not brought up very much in the literature, but it clearly is what's going on in terms of the malformation of the mitral valve.
Yeah. Gordon Danielson used to do something to the mitral valve in 80 to 90% of the patients.
Yeah. Anyway, we have now, we're going to have a few minutes for questions and open to anybody who has a question or a comment. Yes, please.
Dan, just you need to come forward. Need the microphones, do you mind?
Yeah, you can go to the microphone.
My question is regarding the septal thickness and the preferable treatment choice. I think if the septum is over 2 centimeter or 25 millimeter, I think that septal ablation is most likely not going to work. What is your thought?
Absolutely. That's what the data says, and that's what our own experience has shown, because there is such massive hypertrophy, one septal perforator artery is not going to be able to take care of it. Very good point.
More questions? Yes, please.
At the end, it's about reduction in sudden death in many ways. Heart failure, diastolic dysfunction, separate issues. So I have a 22-year-old, and I thank God he's fine. But if we're going to do it by show of hands, understanding the variety and how complicated the disease can be, knowing what I know about medicine today, even though we're quoting 0.65% and 0.5%, now we have defibrillators that can be implanted with a substernal lead rather than intravascular. And I'm not talking about guidelines. Do you think it's totally unreasonable that at one point that preventing a single death would not be unreasonable to put in a device in addition to all the meds, beta blockers and all? The last, and as a separate point, in some of the alcohol ablations, there's plenty of data now to suggest that when you create an infarct that's as a percentage of the myocardium is, let's say, bigger than 9%, may lead to sudden death itself, and we're looking not just an ejection fraction, but sudden death with scarring of the heart.
So I think you bring up an interesting point, at least as it pertains to the subcutaneous ICD. So the risk-benefit ratio for HOCM and sudden death is based on transvenous systems. So there, as he mentioned, there are new subcutaneous ICDs, which are relatively new to the market, which may change the risk-benefit profile to a small degree in the sense that you don't have any risk for pneumothorax, there's no risk for tamponade, and it's relatively easy to put in, and even if you develop an infection over time, it can usually be treated with just IV antibiotics. So I think that will be a very interesting addition to whether or not people decide to put in primary prevention devices for patients that have one risk factor or zero risk factors. Although I think the guidelines still stick in that the patient has to have at least one risk factor prior to implanting the device. Having said that, the data to support subcutaneous ICDs in patients with HOCM is relatively limited. There were patients included in the original 2 trials, but it's not that many patients overall, so I think you have to be careful. Having said that, one last point is you have to remember that in those trials, which are done in perfectly controlled patient populations, still about 15% of all patients experience some complication related to the device, albeit nobody got tamponade or pneumothorax, but there still were inappropriate shocks due to oversensing as well as wound dehiscence, so it's not a perfect solution.
In our group of very young people, less than 30 years old, 25% had inappropriate shocks because of the fact they're active, their heart rate goes up, they might be sensing their T waves, so it's a fairly high incidence.
Antoine, just for completeness, we didn't talk about drugs in terms of the outflow obstruction, and I just like to give a little summary, and you can disagree or agree, that beta blockers do not affect the gradient at rest. They affect the gradient on exercise. Second, verapamil with a gradient of more than 50-75 millimeters of mercury is a danger. And third, disopyramide or Norpace is a good drug because it affects the gradient at rest. It may prevent atrial fibrillation. Is this a fair summary? I don't know, Antoine, and maybe Rick?
No, sure, I totally agree. Verapamil can be very dangerous in patients who have severe LV outflow tract obstruction, and also in those that have severe symptoms at rest. And beta blockers probably will not give much benefit except for just limiting the increase in heart rate, and then because when HOCM patients have tachycardia, then they become also symptomatic.
Rick?
Just a couple practical points, as I agree completely with Dr. Fuster, as I've never not agreed with him. But for the beta blockers, they take massive dosages. This isn't the 50 or 75 milligrams of propranolol equivalent. This is up to 300, 400, 500 milligrams per day. And you adjust not to the gradient because you won't knock the gradient, but to a resting heart rate of 60. But with that, about 50% of patients may have a significant improvement in symptoms. Disopyramide is a wonderful drug. It works very, very well, but you always have to have some element of beta blocker on first before they're given the disopyramide for the danger that might happen with atrial fibrillation and rapid AV nodal conduction. But I agree it's a drug that's underutilized. We should use it more.
Any further questions?
I had one question for Dr. Nishimura as it pertains. So we briefly discussed apical HOCM, but when you see a patient with apical HOCM, do you apply the same risk stratification criteria to those patients for sudden death as you do the regular septal HOCMs?
No.
So you believe there are lower risk cohorts?
No, well, actually, I believe that the risk of sudden death dramatically increases in the apical hokum as they develop their apical aneurysm.
In the absence of aneurysm?
In the absence of an aneurysm, their risk of sudden death is probably comparable.
Comparable.
Yeah.
I'm going to finish by asking each of the panelists, you want to make a comment?
Just, do you use, you're talking about MR stratification.
Yeah, the microphone.
For MR stratification, do you use percentage of myocardium involved in the decision to use an AICD or not?
We do, except I can tell you the 6 standard deviation is a difficult thing to do when you have to be absolutely sure that your MR people are doing it correctly.
Okay, I'd like to ask each of the panelists to make a final comment of what you think is the most relevant aspect maybe discussed today or that you think about the disease, and just one 15-second comment. Martin?
I think what you started by saying is we're seeing this disease more often because of imaging techniques picking it up in otherwise asymptomatic patients, and that's sort of the dilemma of what to do with the asymptomatic, no family history, how far and how aggressive, because in younger people can have a significant impact on their quality of life.
Thank you. Bob?
I think it's very important, and I recommend the gene testing. I think that you need to know in the future genotype, phenotype, so you can correlate, so you can predict in the future. If we don't get that data now, we'll have to wait much longer before we can be more effective in our counseling.
Rick?
It's the heterogeneity and everything, the anatomy, the pathophysiology, and the prognosis, and remembering it's the young person that's going to get in trouble.
Robin?
Yeah, I think the genetics are the most fascinating aspect of this, at trying to ascertain which patients are the ones that are really going to become symptomatic.
Mark?
I think we need a better way to risk stratify the patients. We've done it for AFib, and we have CHADS and CHADS-VASC, but we don't really have a great way of defining who's truly low risk and truly moderate to high risk for sudden cardiac death. And I think it's a source of anxiety for a lot of patients and their physicians.
Good. Antoine?
I think it's as Dr. Nishimura has said, it's a very heterogeneous disease, and you have there's not a clear-cut way to manage patients. Rather than you have to take each patient as an individual and try to do the best for such a patient.
I was happy to hear that Dr. Nishimura uses big doses of beta blockers, because whenever people here see me using metoprolol 400 milligrams twice a day, everybody says, this guy must be crazy.
This is why actually we didn't talk about medications too much, cause more toxicity than help. This is my only statement. Thank you very much.